All right, good afternoon, everyone. Thank you for joining this webinar for the PNQIN Perinatal Mental Health Conditions Bundle. We appreciate you all for being here during the summertime when I know a lot of people are traveling and on vacation. So thanks for tuning in, and we're excited to share some information and resources related to substance use disorders today. So just to start with our usual housekeeping slide, please put your name and institution into the chat for attendance. And our optional share, if you would like to also put it in the chat, as we'd love to learn about your favorite summer travel spots so that you can give everyone vacation envy. Please mute yourselves when not speaking. And feel free to type your questions into the chat as we go. We'll have some time at the end to address those with our speakers. And as always, these webinars are recorded and we upload the recordings and the slides to our website shortly after today. So I'll start with a few announcements and then turn it over to our bundle lead, Dr. Tiffany Moore Simas, just to share a few thoughts about why we're having a webinar dedicated to SUD and the intersection with mental health. And then our guests for today are Gina from MCPAP for Moms to share about their SUD-specific resources, and then two of our PNQIN Perinatal Opioid Project co-leads, Amy and Elisha, will be here to discuss the toolkits for maternal and neonatal populations that we've developed as part of that project. So we'll get right into announcements. Just a friendly reminder for our participating teams that this is our participation checklist for the bundle, and the next implementation feedback survey, item number 4, will be coming out in August. So you may remember if you completed this survey in February, this is just a way for us to check in every 6 months, hear how implementation is going, and collect anything you'd like to share with us about what you may be struggling with, what resources you're finding helpful, so that we can continue to tailor the implementation of this bundle to your needs. So keep an eye out for that survey in August. Also wanted to share that if your team has submitted at least 1 month of data for this bundle, then your data submitter should have gotten an email from me within the last 2 weeks or so with a report for your review. So I'm piloting a format for these reports, and I'd love to get your feedback. Our goal is to share a quarterly report of your individual bundle data moving forward, with the next reports coming out at the end of September. So if you didn't receive that, please just let me know and I can resend it. Also, just a friendly reminder and a thank you around data submission. Thank you all so much for continuing to submit data for this bundle. We know that it's probably the biggest lift, and so we really appreciate the time that you take to submit data. And just a reminder to make sure to check your data for any typos or calculation errors before you hit submit each month. And your care in this review process will help us to collect and report back the most accurate data possible, not only for your site, but for the whole collaborative. So thank you. All right, a couple of announcements. We're excited to share that there is a Spinning Babies and SUD support workshop coming up on September 15th and 16th. On both of those days, the workshop runs from 9 to 5:30 p.m., and the total cost for both days is $450. So the workshop will cover the full curriculum for Spinning Babies, and then there will be a special focus on how to integrate the Spinning Babies approach for families who are in recovery or currently experiencing a substance use disorder. So Brooke is posting some links in the chat while I'm talking, and then I'll also send the information for this out in my follow-up email. Also this fall is the Massachusetts A1 2025 conference. It will be in person in Falmouth. There will be a pre-con training on the safe use of intermittent auscultation on October 16th in the afternoon. And then the full day of the conference will be on the 17th. They have a room block available if you'd like to stay in Falmouth. And just please take note that August 1st is the early bird registration deadline. So after August 1st, the regular registration prices will go into effect. We're also happy to share about an opportunity from Propa City Community Outreach for trainings for providers on perinatal loss. Stephanie Crawford is, if she's here, she is one of our advisory work group members for this bundle, and she does wonderful work. This training has been designed for maternal health professionals and advocates who want to increase understanding and skill to support families who have experienced loss. So this training will explore the various types of loss that families experience, some unique challenges associated with each, and then we'll teach effective techniques and strategies to help families navigate grief and foster healing. So if you're interested in bringing that training to your site, you can contact Stephanie via the email or the phone number on this slide. And then in my follow-up email, I'll include a flyer for this training, which includes the pilot pricing for this training for this year. There's still, I believe, time to support the funding of the Moms Matter Act in our state's fiscal year 26 budget. So if you're passionate about more funding and resources going towards community-based mental health care, you can add your name to their action alert and voice your support as a constituent. And then finally, we have this slide up every month, but MCPAP for Moms is available to come to your site and conduct grand rounds or trainings. So if you're interested, you can reach out to the contact listed on this slide, or you can reach out to me directly and I'd be happy to put you in touch with them. And now I will turn it over to Dr. Moore Simas.
Hi, good afternoon, everybody. We can go to the next slide. So we're going to talk about substance use disorder today as part of our perinatal mental health conditions bundle. And so, of course, just want to make the connection for the why there. So if we think about a quarter of birthing people will experience a perinatal mental health condition, and about 5 to 10% of those will experience substance use disorder during that same period of time. Additionally, in general, up to 50% of individuals with substance use disorder have a co-occurring mental health condition, whether that's in pregnancy or postpartum or outside of it. And then there's sort of these two conditions together. Substance use disorder, of course, is a mental health condition. However, in the world of both AIM and ACOG, they're treated somewhat separately and distinctly in having separate bundles, separate clinical practice guidelines, et cetera. But in general, sort of them co-occurring together results in increased risk to maternal morbidity and mortality, neonatal complications, and the family system impacts. We can go to the next slide. So, what we know from our maternal mortality morbidity data in Massachusetts is that there is, in fact, higher severe maternal morbidity amongst populations that experience perinatal mental health conditions and opioid use disorder. And you can see that on the bottom figure with opioid use conditions, opioid use disorders in the green, having a rate of 127.6 per 10,000 deliveries, and perinatal mental health conditions 112.1. So near highest to highest rates there. We do continue to see disparities in SMM across the board, both in prevalence and in outcomes for Black, Indigenous, and Hispanic birthing people having the worst outcomes, unfortunately, and that holds true in these conditions also. The reasons for the high SMM rate and the disparities are multifold, and some of those related to fragmented care systems. We can go to the next slide, which talks about barriers. So some of the key barriers that we need to address as we're thinking about addressing these things together, these conditions together, and doing so in an equitable way, is that we know that there's increased stigma for mental health conditions and for substance use disorder, and in some cases, criminalization. And that can be even worse so based on race, ethnicity, based on socioeconomic disadvantage, based on language. We know that there are screening inconsistencies across settings and screening inconsistencies also as it sometimes relates to personal demographics. There are limited integrated care models, and even the models that do exist, we find that for the individual like patient or person that's being affected by these, they feel often torn and pulled, between that fragmentation between obstetrics, behavioral health, psychiatry, pediatrics, like who's in charge, where do they go, is there even somebody there, because the resources are not nearly what we would really want them to be. And I know so many on this call are working on that. Next, last slide for me. So we sort of gave the why, which is maybe not inspiring, but concerning, because we have a lot of gaps we still need to fill, but also some solutions, right? PNQIN remains committed to solutions, has been working in the Perinatal Opioid Project for almost a decade at this point. There's some new resources coming out, and I think I say this on every webinar and certainly in many venues, but MCPAP for moms, MCPAP for moms, MCPAP for moms, remains a just tremendous resource for addressing both perinatal mental health and substance use, either substance use disorders, either individually or comorbid together, and just a tremendous resource for both resources in general for patients and getting access to care, and for us as caregivers in supporting us in advancing our knowledge and our ability to address these as individually or together. And I will turn it over to Gina from the MCPAP for Moms team to take us through the next part of the webinar.
Thank you. Hi, everybody. Today, I'm going to be sharing a brief overview of MCPAP for Moms, a program that supports providers in caring for perinatal individuals with mental health and substance use disorder. Next slide, please. Next slide. And our team provides real-time psychiatric consultations and resource support, including a dedicated sub-program for substance use disorder. This includes a medical director. You can see a picture here of Paulina Tesler, Dr. Paulina Tesler. She's got expertise in perinatal mental health and SUD, and then a program manager, myself, who's a licensed alcohol and drug counselor certified in perinatal mental health. And we work alongside our other consultants to guide providers caring for perinatal individuals with complex needs. Next slide, please. Thank you. So how can we help? We have three main services. We have webinars and toolkits on our website addressing perinatal SUD. We provide peer-to-peer consults offering support and guidance around medication management and diagnostic assessment. And that medication management also not just is psychiatric medication, but also medication for addiction treatment. And then the SUD program manager will work directly with patients with substance use disorder conditions to help connect them with community-based resources, including individual and or group therapy and medication management. We can also connect patients with the Family Care Plan Coordinator, formerly known as the Plan of Safe Care. Next slide. Thank you. So this is our website. And again, there's tons of provider resources, but I also wanted to draw your attention to there's a birthing family tab with lots of reliable vetted resources with educational information and a support group finder along with patient handouts. And that's a great resource for parents and families. Next slide. So when you call for a consult, you'll first speak with a resource and referral specialist who will collect key information and connect you with a clinical consultant. You can either schedule a callback or expect a return call within 30 minutes. If you're unsure whether a consult is needed or you have a question specific to substance use in the perinatal population, you can feel free to reach out directly to me by phone or email, and I'll share that information later on. And just a reminder, we ask that you please make sure that the patient has given verbal or written consent before sharing any personal information with our team. Next slide. And so just a little bit more detail about the resources. So there's two options. There's resources to provider, where we can collect, a list of therapists or a list of prescribers that accept the patient's insurance or in the general area. And we can either email or fax that to you. And you can expect that usually within 1 to 3 business days. And then we can reach out directly to the patient. It's most often when it comes to substance use. And so for patient contact, no consult is needed ahead of time. But we do like to have an EPDS score if you have it. If it's 19 or above, or if there's any answer other than no on question 10, we do require a consult with the referring provider before we reach out directly to the patient. And we do make 3 attempts to reach out to the patient over the course of a week. It's usually by phone and or text. And if we don't hear back, we'll still gather a list of resources and send them on to the referring provider. For patients we do reach, we just generally ask about their preferences, if they want virtual or in-person treatment. And we give them a choice if they want a list of names and they can follow up themselves, or we can refer them directly. And time again, we found if we refer them directly, there's better follow through. It's probably no surprise to people, but patients can be very overwhelmed and have the best of intentions of following up, but it's just too overwhelming often to call 3 places and see who you like best. So I found myself very much making a referral. And then what we do is I'll follow up after 2 weeks, check in with them and say, have you connected? Were you able to follow up with the appointment? Do you have any questions or any additional support you need? Next slide. Thanks. And then this is just a list of resources that you're probably very familiar with: the Women and Family Referral Center and their number, their online intake form, the Family Residential Treatment Access, and these are all links to those resources. Next slide. Thank you. And then First Steps Together, Project Nest, the Journey Recovery Project. And again, there's a little blurb on each of them. If you click on them, you'll get more information. And then the last one is a link to the PSI support group for people in recovery. Next slide, please. Thanks. And that's basically it, everyone. I really want to encourage you to reach out if in doubt at all. You don't have to call the 855 number. You're welcome to do that, but you can reach out directly to me. Email is probably best. And thank you for giving us the opportunity to tell you more about our program.
Thank you so much, Gina. Again, I echoed Tiffany earlier that MCPAP is such a tremendous resource for our state. Not every state has a program like this, so definitely do your best to utilize them. Thank you, Gina. All right, and now I'm excited to turn it over to Amy Walker to share with you about the PNQIN POP Maternal OUD Management Toolkit. Hi, Amy.
Haley, hey. And I am a frequent utilizer of MCPAP for Moms. I love that service. It's amazing. So we can go to next slide here. So I'm going to be presenting on a maternal toolkit for management of opioid use disorder in the perinatal time that is soon to be published. We're just waiting for some final feedback from some stakeholders. And with this toolkit, our goal is to provide teams with a group of best practices, resources, sample protocols, and policies from teams that are already doing this work, all in an effort to standardize care and improve outcomes for birthing people and their newborns. Each section, well, most of the sections include a resource section, and so there's going to be some overlap from some of the things that Gina was talking about, which is great because we're providing the same info. This is an example from the expert section on some Massachusetts resources. So Institute for Health and Recovery, Women and Family Referral Center, MASPERT, which is a local resource for training and technical assistance for SBIRT implementation. And then a tip sheet from BSAS on how to make a trauma-informed warm referral. And so that's just a little example of what those resource sections look like. Next slide, please. So what's in the toolkit? So we start with a section on respectful, supportive, and equitable care. This is what I consider to be one of the most important things about how we take care of patients, really that how of how we do it. And just like Tiffany was talking about, pregnant and birthing patients with OUD have often endured stigma. And much of that stigma has happened in medical settings too. And we also know that patients have also endured trauma in their lives and in the medical setting as well. Patients are also coming in with a lot of fear about CPS reporting, which up until recently was required for all infants with prenatal substance exposure, including patients on prescribed methadone and buprenorphine without illicit use. And so we are very excited to talk about today that has shifted, that the legislation has shifted. I'm going to talk about that in a later slide. But the fear of CPS reporting still remains and will remain even with this legislative change. And for pregnant and birthing people of color, research has shown higher rates really at every level of care. So higher rates of toxicology testing, reporting to CPS, and higher rates of infant removal, all with similar rates of documented substance use for the white counterparts. And so all of these things create barriers for both entering into prenatal care and remaining in prenatal care, and also entering and remaining in substance use treatment. Next slide, please. So this graphic was created, oh, it looks like it's cut off a little bit there. Not sure why that happened, but so this is a slide that was created by Mass General and by Dr. Davida Schiff and team to talk about the effects, the harmful effects of mandatory reporting practices for all patients with substance exposure. And so on the top, you can see this person who is been prescribed methadone or buprenorphine, doing what is recommended. And in systems where mandatory reporting exists, this leads to a lot of frustration, fear, stigma, and sometimes increased anxiety, which can create the potential for health implications like stopping taking their methadone or buprenorphine, which can be a risk for relapse. Negative health implications if they are too afraid to come to prenatal care, which I know that we have all seen this happen. And we want to try to create a better pathway. And so the bottom is this better path where uncoupling treatment decisions from CPS reporting focus on service delivery and not surveillance, and building up our resources to support families. These are the things that can improve outcomes. And, you know, due to some incredible work in Massachusetts, a lot of this has already been worked on. And like I said before, I think it's going to take a lot of time for patients to build up trust in the system. And I think that there always will remain some fear about coming into care for patients who are in treatment for SUD. Next slide. So we're going to talk about how we all can be a part of the solution. And so some of the things that we can do that are talked about in this toolkit: practice trauma-informed care, honoring patient autonomy, and remembering that this patient coming in is the expert in themselves. You are also adding into your expertise about obstetric care, but this patient knows themselves best. And because of this, we have to practice shared decision-making. I know not everybody loves that term because the patient is the one that is making the final decision, but the meaning of this is that we are sharing all of the information with our patients so that they can make the best decision. And sometimes that requires talking about alternatives because they might have fear about recommendations that we're making. And other work that we can do towards continuing or implementing best practices, especially with these new legislative changes. And make sure patients know their rights. And on the right-hand side is another tool that is both on our website currently and also in the toolkit that was created by Dr. Schiff and team for patients to know what their rights are in terms of when they come into care. And we also want to practice harm reduction. And my hope with this toolkit, and also just as we go forward, is to weave in harm reduction in everything we do, and also the respectful and supportive care. Next slide, please. So our next section focuses on screening, brief intervention, and referral to treatment, which I'm sure folks are knowledgeable about. But this really goes through all the steps for what the best practice for identifying patients at risk is to utilize universal screening with a validated tool at the entry to prenatal care and at the birth admission. And we also recommend screening in the 3rd trimester and postpartum. And just a reminder, screening is not the same as urine drug testing, which we're going to be talking about shortly. And the nice thing is that the timing of this can pair up well with using the EPDS, and so, or other screening tools that you're using for perinatal mental health. Next slide, please. So I include in here examples of screening tools that are in the toolkit. So on the left-hand side is the 5 Ps. I'm not sure, I don't know why my images are cut off on the top. It wasn't like that on my PowerPoint. So let's see. I make
So sorry, Amy. We'll
That's
make sure
okay.
that they're fixed when
No,
we
I'm
post to
sorry.
the
I'm so
website.
sorry. I maybe I didn't look at it correctly, but apologies. But we can fix it for the one that goes out. Yeah. So on the left is the 5 Ps, and on the right is the NIDA quick screen. And the NIDA quick screen is a short tool that then, if there's a positive answer, it feeds into the NIDA modified assist, which is a longer screening questionnaire. Next slide, please. And then I also include in here, this is an excerpt of something from MassSpurt, which shows how to do a brief intervention. And so if you're doing a screening and someone has a positive response, this gives some scripting for providers to how to have this discussion, which is like a mini motivational interviewing, where you're drawing from patients about what their motivations for cutting back or quitting are, and you're utilizing that in your counseling. So this is a nice reference guide, which we'll include. Okay, next slide, please. So the next section is on toxicology testing. So this is typically urine drug testing, or sometimes people are utilizing other types of testing. And this section covers how to use and how not to use toxicology testing, including the importance of obtaining consent, preferably written consent, and how to interpret results. I want to stress that confirmatory testing is always needed for unexpected positives. And unexpected positives, false positives happen, and they happen quite a bit of time. So it's important for providers to know how to figure out when they should be doing confirmatory testing, how to interpret things like positive fentanyl in the urine as well. And so these tools will allow for providers to be well informed. And also this section includes Boston Medical Center's policy on toxicology testing, which has an example of a written consent. And they also have a great tip sheet that we include on fentanyl interpretation, because there's a delayed clearance of fentanyl in the urine for pregnant patients. Okay, next slide, please. So the next section, we have a large section on medications for opioid use disorder. And so continuing or initiating MOUD for treatment of OUD in pregnancy is the standard of care. And I feel like I know we've been talking about this for years, but I feel like it's important to stress that, because there's a lot of stigma for patients being on methadone or buprenorphine in pregnancy. And, I see it all the time in my program, patients feeling like they're receiving stigma maybe in their residential treatment program, or, sometimes by an offhanded comment from someone. So it's important for us to evaluate our own biases when we're caring for patients, and the how we're talking to and talking about this. We know that MOUD decreases the chance of return to use, and it is life-saving. This reduces the chance of overdose and death. And then MOUD plus prenatal care has also been shown to decrease the chance of OB complications. This section includes for providers what to expect in relationship to dose increases in pregnancy, the benefits of split dosing, challenges that might come up with initiation onto MOUD, and there's also information on extended release injectable buprenorphine like Sublocade and Brixadi, which are becoming more frequently used and can be a great tool. Naltrexone and medically supervised withdrawal. And then we also include several sample protocols for initiation of methadone and buprenorphine. And so next slide, please. We have a couple sample ones that are in here. So this one is from Boston Medical Center. This is their inpatient induction onto buprenorphine. And next slide. This is a segment, again, I'm so sorry for the view here, but this is a segment of Mass General Hospital's policy for induction onto methadone inpatient. This one also includes buprenorphine, and we also include an outpatient buprenorphine injection as well. Next slide, please. Okay. So as was covered at the beginning of this webinar, screening for perinatal mental health conditions is very important for this population as well as as all populations, and partly because co-occurring mental health conditions are very common for patients with OUD, and we want to help patients to create stability, and so we want to remember that if we don't treat mental health conditions, or if they're undertreated, this can be a risk factor for destabilization for patients with OUD. A lot of what I do in my program is around mental health coordination or mental health care. This section is linked a couple of times in the toolkit because it's so important, and we include resources like MCPAP for Moms, Postpartum Support International, and we also have a link to the AIM bundle toolkit as well. Next slide, please. Okay. So family care plans, this is the term that is used now. It was formerly called plans of safe care. And for all infants with prenatal substance exposure, the federal CAPTA requires that a plan of safe care or family care plan is developed for a family before the infant is discharged from the hospital. And so what this is a comprehensive plan that addresses patients' needs, both needs surrounding their substance use disorder or needs for their mental health and physical health needs, and can also include and should also include safety planning around destabilization or return to substance use. There are some templates that already exist through Journey Recovery Project, which is a great resource, and also on mass.gov. Currently, there is some great work happening at the state level that started with the in-depth technical assistance work, and there is a template being piloted right now that should be coming out in the next few months. That will be a great resource. Next slide, please. So I want to focus a little bit on the legislative changes. So December 2024, after much advocacy, and I want to just include that this was by patients with lived experience, healthcare providers, and other organizations, a law was passed that included the removal of the mandatory filing for infants with prenatal substance exposure. And this also includes uncoupling the reporting of family care plans to DPH from DCF filing. And it is going to create a dual notification pathway because the state still needs to meet that CAPTA requirement. And so this will be a way that can be fulfilled without having to be a DCF referral. And so several hospitals have already made changes to their policies for reporting, and the toolkit provides tools and examples to help support policy changes. So if this is something that your hospital hasn't done yet, we'll have support for you in how to do it. And what we recommend is that the hospital teams have a policy around reporting to CPS, which reflects this updated legislation and takes into consideration ways to maximize support for families and reduce bias in reporting decisions. New regulations are going to be forthcoming probably in the fall from both DPH and DCF. Initially, when we publish this toolkit, they won't be available, but we'll update it as soon as it's available. And there's some language surrounding this legislative changes. Next slide, please. Okay, so additional topics. We have a lot of other things that are in the toolkit. So this is like a little overview of the other things. Harm reduction, including links to a great provider-facing toolkit and patient-facing toolkit that's available. We have information on PrEP, which is pre-exposure prophylaxis for HIV. Peer recovery support services, including resources like Moms Do Care and First Steps Together. The next 3 sections are separated by timing, so antepartum considerations, including coordination or co-location of care, which I know Dr. Moore Simas was referring to, how sometimes care can be really discombobulated for patients and they don't know who to kind of go to, who's making this decision. And so if we can coordinate care more, or in some places we can co-locate care, like having psychiatry and OB and addiction medicine all together. These are great ways that we can improve the care experience for patients. We also have links to information on doula care, infectious disease screening, fetal testing, creating and using prenatal checklist in the EMR, and information about consultation with pediatrics and anesthesia. In the intrapartum consideration section, we have information on pain management considerations for patients with opioid use disorder, both who are on MOUD or not, and an example of a policy, breastfeeding, and information on reporting to DCF. And then the postpartum considerations, this is, of course, as we know with perinatal mental health, the postpartum time is really important. And also it's a time where traditionally there's been a drop off in care. And so we want to think about how can we improve the care in the postpartum period and improve wraparound supports. If you're not able at your site to provide continued postpartum care, what groups can? So for somebody to a program like Moms First Steps Together, somewhere where they can continue to get this vital connection in the postpartum time, because we know that the postpartum time is a risky time for both for mental health complications and also for return to use, and carries the highest risk for return to use, particularly in the 6 to 12 months postpartum. Also in this section, again, we have information on doula care, postpartum support groups, screening for perinatal mental health, and then an excellent section on contraception that was edited by Dr. Miller, which really talks about the importance of providing low barrier, so easy to access, goal-based reproductive health counseling for patients using shared decision-making. Next page, please. And lastly here, I just have a review of the appendices for folks that are all included, and all of the images and tools that we shared today in this presentation are also included in the toolkit. Next slide, please. This has a list of our editorial team, which we had a great team, and I want a big thank you to the PNQIN admin team as well. People are welcome to reach out to me with any questions. As this is not yet published, once we publish it, we will put it out to this group as well. But if you have a need now for a resource, please feel free to reach out to me. Thank you.
Thank you so much, Amy. And yes, we will keep everyone updated once the toolkit has been posted. But again, the slides of Amy's presentation will be posted. So if you saw something from the toolkit that you thought might be useful and just want to double check, you can check out the slides and reach out to Amy for any of the resources. Before we move to our next section, we did get a question in the chat from Michelle asking what sites are using for SUD screening in the inpatient setting. So if anyone has an answer for Michelle, please feel free to put it in the chat, and we can also come back to that during our Q&A portion. All right, thank you again, Amy. All right, and our last speaker for today is Dr. Elisha Wachman, who will be providing an overview of PNQIN POP's neonatal toolkits.
Hey, thanks so much. And I can share screen. Let me see.
Elisha, your audio is a little bit choppy.
Um,
Oh, it seems to have,
is that
I
fine now?
think it's
Sorry,
straightened out.
can I share my screen? Okay.
Yes.
Yeah. Okay. I think you might have to take down yours.
Okay.
Potentially. Okay.
Oh, I
Let's
see.
see. Okay, let me see. All right, you guys can see that okay? It's fine.
I think you might need to, there are a couple of like black boxes where maybe the Zoom
Let me
features
see.
are.
What about now? Is that better?
There's still one at the top. I don't know
Um,
if there's a way of getting rid of that.
is it gone now? Maybe.
Now there's one in the middle. It keeps
Oh my
moving.
gosh.
Okay, there we go.
It's gone.
Perfect.
Okay.
Yes.
All right.
Thank you.
Sorry about that, guys. So this will actually be really, really quick. I'm just going to give a very brief overview of our neonatal toolkit, just for those of you who haven't taken a look at it. And actually, I'm just going to give a brief overview via the PowerPoint and then just go ahead and show you the websites. So here are the toolkits. And again, there are two of them that do have passwords that are required, which I'll go through when I get there. But they're all linked from the primary web page. And so we, again, we have the neonatal toolkit, which I'll go through, which has the basics that goes over inpatient management for infants with neonatal opiate withdrawal. And then, yes, I think it'll be easier if I just kind of show you guys. And then I'm going to go over next kind of our Eat, Sleep, Console training page as well. And so I'm just going to, I think it'll be easier if I just show you the web page rather than the slides. So let me, hopefully you can see this okay. Can you guys see the web page?
Yes.
Okay, so this is our main perinatal opioid project page. And so to get to the toolkits, and this will also be applicable for when the maternal toolkit is added, at the bottom, you'll see our neonatal toolkit. And this is one in which you can access without any password. And so you'll see a couple of things. And so the first thing to note is that we update the toolkit every 2 years. So it's due to be updated again this fall, just to make sure that we have the latest best practice recommendations and latest references included. And so if you click on this button here, it'll take you to the actual PDF document of the toolkit, which let me see, hopefully it will pull up here for you guys. Perfect. So, let's see. If you take a look here, we have our table of contents. So you'll see we have an overview of the prenatal consultation, what goes into the initial admission of a baby who's being monitored for neonatal opiate withdrawal, including the toxicology testing, which Amy mentioned, about the scoring tools, and then it goes into treatment, starting with non-farm care and then farm care. And just to give you an idea of what some of the sections look like. So for instance, for a prenatal consultation, it will include some talking points as to what should be included as part of that prenatal consultation. And then when you go into sections such as length of inpatient monitoring, we always make sure that we include references for, again, the latest best practice for where we made these recommendations based off of. And then, going down to, assessment tools, again, there's a brief overview of both the Finnegan and the Eat Sleep Console, the evidence to support both. And again, so this is very brief and I think really great, particularly for, residents and trainees. It's sort of a really concrete summary of care with best practice references at the end that they can refer to. Again, there's a summary of breastfeeding, farm treatment, and at the end we have a summary about planning for discharge, and so kind of a discharge planning checklist here as well. The other thing that we've included is sample protocols. So there's a sample, for instance, prenatal care consultation template that was provided by one of our hospitals where you can click and again just modify. I don't know why this, of course, is not working today, but there is a template here. We also have sample guidelines. So we have guidelines for toxicology testing, breastfeeding, NOWS, pharmacologic treatment, all included in the toolkit. So in addition to that, there's two areas that we've provided additional resources. And the first is regarding Eat, Sleep, Console. So if you go up here, this page is password protected because of some of the materials that we've developed that were meant for our collaborative. So if you go here to ESC training page, the password will be provided with us, but as ESC 2023, hopefully it will load very slowly here. Yeah, so you'll type in the password, it's ESC 2023, enter, and you'll see the materials that we have here that give you a little bit more detail about the approach. You can do it, load. Okay. So you'll see on the training page, we have a number of resources. So the first one to point out, there's a link here to a general NOWS 101 talk that I gave a while ago that you're welcome to utilize again, particularly with trainees. We have provided here, again, a overview PowerPoint that you can also use with your staff, as well as a number of best practice of articles. So we've included, again, the clinical trial and some of the initial articles about use of ESC are all linked on the page. For training resources, we have a couple of things just to note here. So again, the tool is here. So you'll see both the second and the third edition tool. The third edition is the latest one that we're able to post. And you can see you'll have it here. The paper version of the form is here. And we also have a training manual. So this manual has a little bit more details about the descriptions of each of the items, which might be helpful again for staff to read through, where this is again a much more detailed description of the tool and goes into a lot of details about, what defines poor eating and things like that are all included on the page. We also included a inter-rater reliability tool and a newborn care diary. So all of that is included. We are working on getting the video back online. So currently the video is not available, but we are hoping to get it back online. However, the manual includes all the details which are in the video. So you still have the information. The only other thing I just wanted to point out too, I think it's under implementation, maybe not. There was an EPIC toolkit, but I don't see it here, but we can make sure that that's back online too for how to build it into your EPIC if you don't have it. We included a section here if you're looking to kind of do a slower transition off of the Finnegan tool, that we have some symptom prioritization examples on how to do this kind of in-between step. So again, all of that is included here on this password protected page, which you are welcome to use as a member of PNQIN. And then the other last piece, in my final 2 minutes here, is to talk about is that we also provided additional details about how to start a cuddler program. And so this page is also password protected, because it contains, a video that was made, again, for our collaborative. So the password is NeoQuick 2021. again, that'll be provided afterwards. And we have materials from Boston Medical Center as well as from Lawrence General Hospital, who provided details of their Cutler program. So specifically, for BMC, we have a copy of our volunteer guidelines. So kind of what we hand to volunteers for the training. We've included here. So all of the guidelines for how to report to shifts and things like that. We have like a requirement checklist for, what do you need to do to become a volunteer? And then we actually have a training video, which again, you're welcome to look at, adapt for your own hospital, and that you can look at. It's a video link that has our orientation video that we give to all of our volunteers. And again, Lawrence provides similar materials where they provided their job description, orientation checklist, and scheduling template. So again, just hopefully some practical tools for those who are looking to add this supportive service to their NOWS program. So I believe I covered everything. I know I made these slides and realized I really just wanted to show you the webpage, but if you have questions on the content, you're welcome to contact me. Access issues, you can contact the main PNQIN email address. And again, I'm just going to end with showing you those passwords again. So again, for the ESC page, it's ESC 2023, and for the Cutler page, it's NeoQuick 2021. So that is it. I'm going to take down my slides and we can open it up for questions. Let's see if I can back to.
Wonderful. Thank you so much, Elisha. Yeah, lots of time and work went into all of these toolkits from POP. So I just want to thank Elisha and Amy as our POP leads, as well as the POP leadership team behind a lot of this work. So, okay. Well, we have about 9 minutes left in our webinar for any Q&A or discussion about anything that we saw today from our speakers, Tiffany, Gina, Amy, and Elisha, or just sort of general questions about caring for patients with substance use disorder and/or co-occurring mental health conditions. The lines are open. I'll just check the chat for any questions. For Michelle, who asked earlier about what sites are using for SUD inpatient screening, Sturdy is using the 5 Ps. Thank you, Hannah. And then Cooley Dickinson uses Audit C and NIDA single question. Thanks, Amy. I don't see any other questions at the moment, but feel free to put them in the chat or come off mute. Oh, Courtney says South Coast Health uses the 5 Ps on admission and Audit C. Thanks, Courtney.
I'm wondering if Jesse might want to share a little bit more about, if there's no questions specifically related to substance use disorder around the Mom's Health Matters.
That's a great idea. Yeah, Jesse, and then Hannah will take your question.
Yes, so I was on vacation, so the announcement is coming a little bit late, but there were a couple of remaining steps in the state budget process. The conference committee budget, and then the budget went to the governor's desk. We have a coalition called Mind the Gap Coalition. Very diverse folks from all across the state, different types of institutions, individuals who are survivors of PMADs, and we've been advocating for something called the Moms Matter Act, and that is a grant program that would issue grants to community-based organizations that do something that supports either PMADs, SUD care, grief and loss, and we were able to get $220,000 in the FY26 budget. So that will be issued in grants from the Department of Public Health next fiscal year, which is starting now. We haven't checked in with them yet on any more detailed timing. But I want to thank PMQIN and everybody here, because every time we put the word out, Callie put it in the newsletter and people wrote a whole lot of letters, and that was really made a huge difference, particularly around geographic diversity. And when you when you fill out the form, it goes to your legislator. So as we were making the rounds of the State House, we would visit an office and start to talk about the issue, and people would say, well, legislative offices would say, oh yeah, I got some emails about that. Yes. So people really stepped up, and it was clear that there was broad public support for this, which is really exciting. I think, this isn't a huge allocation, but beyond MCPAP for moms, this issue which is absolutely huge, but there's more to do. It hasn't really been on the map as much at the State House. So I think just as important as this particular program and allocation is just keeping this issue front and center for legislators, because it is so common. It hits every community.
Thank you so much for the overview and the update, Jessie. It's amazing news. I'm so glad we could help.
Thank you.
Wonderful. Hannah, I saw your hand up earlier. Did you have a question?
Yeah, so I just have, this can be a question for the group, for anyone that's familiar with the 5Ps and uses the 5Ps, or just any feedback on if there is a screening tool that is like one recommended over the other. 'Cause one thing that I've always wondered with the 5Ps is, with there being the questions about, the patient's parents, if they've had issues with, drugs or alcohol, their partner. I worry about them not always being possibly truthful on the questionnaire, out of fear, like say if one of their parents is with them or their partner does have a problem and they don't want to say something, if there's recommendations on how to kind of go around that so we can make sure that we're getting truly honest answers, so we are providing the care that they need. I hadn't heard of the other screening tool that was mentioned today, so I don't know if that kind of doesn't dive right into those questions, and that's more in the detailed assessment.
I'm happy to weigh in a little bit. So, in terms of ACOG does not recommend one over the other. They just recommend doing screening using a validated tool. And when we look at what is most effective, there's different rates. I think it's probably a hard thing to study too. I think the 5Ps probably has slightly higher rates of being thought to be more accurate, and DPH is going to be coming out with guidelines, and I think they're going to be offering different tools, but I think they're going to be recommending the 5Ps. I didn't come out strongly favoring one or the other in our version because ACOG doesn't take a stand on that, and I think that people in different institutions have different limitations based on their EMR and what's available, and so the important thing is that you're doing the screening. And what I also recommend is that doing the screening multiple times, because sometimes you're right, a patient might not feel comfortable enough to be honest because of all of those barriers that we talked about. And so if they have a chance to form a relationship with a provider, they might feel more ready to be open and honest as we go along. And so that is what I would recommend.
Awesome. Thank you so much.
Great. Thank you for your question, Hannah, and thanks, Amy, for the thoughtful response. I'm not seeing any further questions in the chat, so I'll do one last verbal call for questions. If anyone has any. Okay, wonderful. Well, with that, we'll close out. I just want to take a second to thank all of our speakers again. We are so lucky to have such a wealth of knowledge of expertise about SUD and perinatal mental health care in our state. So I hope everyone found this webinar helpful. Again, we'll be posting the recording and the slides to our website afterwards. Please keep an eye out for the next implementation feedback survey coming out in August for you PMHC bundle teams. And then our next webinar will be August 19th at 12 p.m. We're excited to feature a couple of teams and how they are currently collecting data for the outcome measure for this bundle, which is around referrals to treatment for perinatal mental health. So we're hoping to shed a little bit more light on that measure and how people are collecting it, because we know it's a tricky one. So we hope you can tune in August. Thank you, everybody. Have a great rest of your July. Thanks, Amy.